안녕하세요. 물리치료 읽어주는 남자입니다. 클리닉에서 환자들을 치료할 때면 어깨에 불편함을 호소하는 분들이 정말 많다는 것을 알 수 있습니다. 여러분도 환자 중에 어깨에 통증과 불편함을 호소하는 분들이 꽤 많을 거라고 생각합니다. 어깨 환자를 보다 보면 정말 많은 것들을 고려해야 된다는 사실에 마주하게 됩니다. 통증이 목, 흉추나 복부에서 리퍼되기도 하며 심리적인 부분이나 레드 플래그, 옐로우 플래그에 대한 부분들을 고려하기도 해야 합니다. 그리고 나이, 성별, 흡연, 일반적인 건강상태, 유전력, 과거력 등등 수많은 요소들이 어깨를 괴롭히고 있습니다. 그리고 어깨의 통증에 대한 부분들이 많은 환자들에서 단순히 어깨의 문제에서 오는 것이 아닌 것을 알게 됩니다. 우리는 지난 몇십 년간 어깨의 질병에 대한 분류와 임상적인 평가들을 하기 위해서 많은 시간을 할애했습니다. 그리고 많은 연구자분들이 새로운 논문을 다시 써내고 새로운 연구들이 어떤 주장들을 뒷받침해내고 우리는 그것을 임상에 적용하는 이러한 끊임없는 작업들을 계속 해오고 있습니다. 지금 저희는 너무 좋은 세상에 살고 있으며 클릭 하나만으로 자료를 열어보고 공부할 수 있는 시대에 왔습니다. 여기 제레미 루이스라는 영국의 NHS Consultant Physiotherapist며 JOSPT 편집장이기도 하고 어깨에 대한 연구를 계속 해오시는 박사님이 계십니다. 이분의 이야기를 들어보죠.
So we've got all these special tests, and there's probably 100, 101 of them that we've all spent time learning to do, that some of these tests are used to identify conditions such as impingement, or maybe identify the involvement of a structure such as the rotator cuff. And we could ask ourselves a question when we're in our clinical practice, what do we actually know about these special tests? I guess one of the first things we've got to say is multiple narrative and systematic reviews from wherever you look at them consistently are telling us that these special tests can't tell us or can't differentiate structures. They can't tell us where the symptoms are coming from. So what I guess we could summarise from that is these special tests aren't special at all. They are tests that are really good at reproducing symptoms, but they are not good at telling us where the symptoms are coming from. And let's just have a look at some of the reasons why that's the case. So all of us will have learned the supraspinatus test, the full can and empty can test, that we're told in the Roman emperor position you're going to die. If it's more painful, more weak in this position, that indicates that it's probably some sort of supraspinatus involvement in our patient's shoulder condition. However, not possible. Why isn't it possible? Because if we look at some studies where they put needle EMG around the shoulder muscles, they're telling us that 8 muscles are working equally hard during the full can test and 9 muscles are working equally hard during the empty can test. So you're not able to say with any confidence at all, I'm testing the supraspinatus during this procedure. And we know that these tests don't have any real validity in coming up with a diagnosis of supraspinatus muscle or tendon involvement. They are great when the patient says it's sore to say, yes, your shoulder's sore, but not telling us why the shoulder's sore. So you've all learnt tests for infraspinatus, subscapularis, supraspinatus, and that's really much based on an anatomical premise that we're testing one structure per test. Now, if we were testing one structure per test, that just might be possible. But that's not the way the shoulder's designed. We've got a really big ball sitting on a really small socket that probably 3 or 4 times larger than the socket, that sometimes has to tuck your shirt in, sometimes has to pitch baseballs at 170 kilometres an hour. And there's no way, if you were given the job of stabilising this ball and socket, you wouldn't put one tendon here, one tendon on top and one tendon at the back. You would make a structure, as is the structure of the rotator cuff, where everything's interwoven and meshing together. So we've got fibres of teres minor inseparably joining fibres of infraspinatus, inseparably joining fibres of supraspinatus. Supraspinatus joins subscapularis to make a covering around the biceps, and that's just at one horizontal level. These guys, Clark and Harriman, were telling us back in the 1990s that it's not just at one horizontal level, we've got 5 separate tissue layers where we've got interweaving not only at one level but through the levels as well, joining up with capsular and ligamentous tissue. So that clearly tells us that this can't be a test, these tests can't be testing individual structures. It's even more complicated than that because you've got lots of bursae in the shoulder. They develop in response to friction. And the biggest, subacromial subdeltoid bursa, like all the other bursae in the shoulder, they're innervated. So we know the subacromial bursa is innervated by branches of the suprascapular nerve, a C5, C6 nerve posteriorly, and it's innervated anteriorly by branches of the lateral pectoral nerve. Now the problem with that is all the tests you've learnt, such as the supraspinatus test, we're told we're testing a tendon. I've said to you a minute ago that's not possible because of the way the shoulder muscles and tendons are designed, but it's even further complicated by the fact that that can't be a supraspinatus test. Why isn't that a subacromial bursal stretch test? It could be equally bursal stretching and compression as well. And you must have asked the question on the morning that you learnt the supraspinatus full and empty cans test, and then you went off to have a cup of coffee, and you came back after the break, and then the teacher said, now we're going to learn the O'Brien test. And you're saying, that's interesting, that looks like the supraspinatus test, but it's now 15 degrees to the left. It looks exactly the same, but now I'm being told that's a labrum test. You should have asked the question, how do we know it's only testing the labrum? Why is it not a subacromial, a subcoracoid bursal compression test? So we've got this problem that the tests that we use are good at reproducing pain, but not great at telling us where the pain's coming from. So our first major conundrum is that we can't make an effective clinical diagnosis.